So, shalom, good afternoon, good evening, and good morning, depending on where you're following this meeting from. I'm really happy to see that we have participants joining in from all over the world. To all of you, welcome to this Bayer Israel initiated event on digital health. My name is Hugo. I'm the Managing Director and Country Division Head for Bayer Pharmaceuticals in Israel, and I will be the facilitator for this meeting. So, we started planning this meeting in the middle of the COVID pandemic, but we did not want this meeting to only be about COVID. The revolution in digital health started long before COVID. It may have accelerated during COVID, but the enormous innovation and changes we are witnessing will for certain continue long after COVID is gone. But in order to drive innovation and change, we need innovative people with an entrepreneurial mindset who are willing to set the agenda and lead the way. And today, you will meet some of these people. Sean Karen, Senior Vice President of Digital and Commercial Innovation from Bayer is here. You will hear from Sigal Rosenberg, who is the CEO of Mohedet, one of the 4 Israeli sick funds. Eyal Simlichman, Deputy Director, Chief Medical Officer, and Chief Innovation Officer at Sheba Medical Center here. And also, in addition, 2 great representatives from the innovative Israeli ecosystem, Kira Radinsky from Diagnostic Robotics, and also Eyal Baum from Taito Care. With that being said, I would like to start the meeting and hand over the word to Sean Karen, again, the Senior Vice President of Digital and Commercial Innovation in Bayer. Please, Sean, the word is yours.
Thank you very much, Hugo, and thank you for that invitation, which it's really an honor and a pleasure to be with such an impressive panel. And so I'm going to really give you a short overview of where exactly we are trying to go now, considering the challenges ahead of us in terms of digital business and digital strategy for a pharma company. Usually, pharma companies are considered as old, slow-moving animals, where their compatibility with the digital world may not be that obvious to start with. So if you can go to the next slide. Thank you. We are part, as a pharma company, of the healthcare ecosystem. And the healthcare is across the world facing really some obvious challenges. One is due to the demography. And because we have more and more people having higher needs and quite expensive needs that we need to take care of. And this is driving really the demand in terms of cost, but also in terms of number of people who actually need to be there for the patients. So it's not only a money problem, it's also a problem of the number of healthcare professionals that are available for helping the patients. We've got that constraint, which is that you can't grow forever the healthcare budget. And at the same time, if you look into some specialties and in some areas, you've got a cap on the number of healthcare professionals. And it's becoming more and more difficult to find the appropriate volume of FTEs just to support the healthcare cost. So the burden of cost is shifting more and more toward the patients too, is what we see in the US with higher and higher copays. You also have a coverage shift in many countries in Europe where not everything is covered and more goes to the patient. And you've got that very big system of healthcare being crunched between the economic constraint and the demand, which is increasing. And the demand is also something that we cannot deny people to have access to healthcare, and it's really a source of social tension. So somehow we need to find a way to unlock that tension and to make sure we find solutions that can really relieve that healthcare crushing paradigm. Next slide. So we are considering that digital tools and technologies are a good way to unlock the problem and to find something where we can provide value to the different stakeholders in the healthcare system. We are working on setting up a group called Integrated Care, and it's something we established in my function. And the goal is there to really look for innovative healthcare proposals based on digital technologies. And those solutions may or may not be related to some of the drugs we are developing or carrying already. They are really meant to be standalone to support the patient needs. One of the big problems or pain point we identified actually in the healthcare system as it's practiced now is really the need of higher coordination and higher empowerment for patients. When I say that, it's also when we say the patient need to be empowered. It's something I've been hearing in the pharma industry for more than 10 years. But are we providing the tools and the means for the patients to really be empowered and to really be able to coordinate the different aspects of his or her life and the care? It's all about making sure that we look with the patient eye on how we can provide solution to manage not only the aspect of care that goes through the healthcare provider, but also the aspect of care which is in behavioral changes, which is in application and better understanding on how one can manage his or her health. We have looked into the entire landscape, and there is such a great activity right now in the whole healthcare and digital healthcare landscape. It's really impressive. We are using our G4A platform to capture a lot of that. And what we see is that strategically, there is a kind of a roadblock for a lot of those initiatives to go off the ground due to a lack of scale and due to a lack of integration. So what we are trying to do is through integrated care and also through another aspect of the strategy that we call marketplace, we are trying to provide a consolidation to really get the interesting solution to scale. If you can go to the next slide. Thank you. Yeah, this one. So overall, what we want to provide first to the patients, first to the people, is actually something where you can integrate everything. We don't want people to have to struggle in the digital world as they struggle into the analog world, going from either different healthcare providers or different applications. We really want to scale something where you can have a holistic approach to managing health. And we are starting to build that in collaboration with OneDrop IDS to have a backbone architecture built by OneDrop where we can progressively populate with modules that will first help to integrate the different aspects of care. And second, using, of course, a lot of data analytics in the background, progressively also customize, personalize the experience of care for the patients and for the people, and making the act of taking care of your health less of a burden, and also getting more done because it's easier to do it that way using the digital tools. So it's overall the direction where we have started to build within Bayer, and where we are really trying to assemble inside and outside to get things moving in the right direction. I will stop here and hand over back to you, Hugo.
Thank you so much, Sean, for that excellent and interesting introduction. And I actually believe that we have time for one question. So, building on what you said about change, what do you think all these changes in digital health means for not only Bayer, but the pharmaceutical industry in general?
I think that, thank you. It's a very good question. I mean, it's time for the pharma industry to really question the role we will want to bring forward. To what do we want to continue bringing? Are we going to continue focusing only on molecules, or are we going to also extend toward a more service-based approach? We have seen more and more industries being disrupted by the intervention of digital, because now you provide something physical, but you also need to provide some services that can be connected to your initial proposition or can be extending your business beyond your initial proposition. And I think that the rise of the digital healthcare is going to drive us, pharma, as an industry, in that direction. And that's why we have started to really invest into that direction, because I strongly believe that the digital tools and technologies are going to help us enriching what we bring to the patients, but also different stakeholders in the value chain, being the payers and the HCPs.
Thank you so much. Excellent answer as always, Ram. So thank you so much to Sean Karen. We will move on in our program to our next speaker. And a while ago, I opened up a local newspaper, and there was an interview with the next speaker. And the introduction was the following: you should always dream, and dream big, so that you ensure that you leave a mark in all that you do. These are the words of our next speaker, Sigal Rosenberg. Mrs. Rosenberg is the CEO of Mohedet, which is one of the 4 Israeli sick funds. And she is the first woman also to lead a sick fund here in Israel. She has a loud voice, and she's an outspoken ambassador of the digital transformation that is definitely needed in the healthcare system. So, Mrs. Rosenberg, please, the word is yours.
Hugo?
Yes, we can hear you.
Okay, thank you for the presentation. I can't see my slides.
It comes here.
Okay. So, okay. Today, in 10 minutes, I will introduce you the digital health and transformation factors in a strategy, in the strategy of Mohedet. A little bit about Mohedet. Mohedet is the third health HMO in Israel. We serve 1.2 million members. We are really early adopter of new technology, and we seek for disruption models. That's what we like to do. We are pioneer in the concept of hybrid medicine, not call center, really hybrid medicine, and I will speak about it later. Offering vast health services with the best doctors and medical teams through a multi-channel accessible approach. Using a really robust digital platform. We have 3,500 physicians, 1,000 nurses, 300 clinics, 120 pharmacies, 100 dental care clinics. We have ownership of the second largest private hospital chain in Israel. It's called Medica. And we have a living innovation lab for new technological and models, providing fast piloting and scaling up capability within the organization. This is Mauchedet. And like the early speaker thought, the healthcare trends are really more integrative, more available, more personalized, and more affordable. This is our new era. This is what's going in the 5 or 10 years. We are going all together to develop and create a new, I think, a new healthcare system. The disruption opportunities, as we can say, provider level disruption trends. The self-care will not be only the self-care. We are going to stretch the abilities until reach a more advanced stage. Like self-care can be like a little bit like the nurse practitioner, the family personal. The nurse can be a little bit like a family personal care physician, and the family personal can be like a specialist. And also in the point of care of disruption trends, I think the home will be something else. Also the office, maybe less clinic, the outpatient will come maybe home or office, and the hospital will be something else that is not the models that we know today. I think this is the trends that's going. We are going together to create. Digital health as a core pillar in Mauchedet strategy. We invest in a robotic telecare platform with the Amwell. I think we are the first to introduce a hybrid primary care service in the primary care, in the basic primary care. The all physicians in Mauchedet have the system, but it's only a system. It's only a platform. Now our responsibility is to do something else with this platform. We in the Corona was the best CTO. The best accelerator for digital trends or digital services. But now, after we have the platform and also the doctors and the patient know how to use it, it's our responsible to do something else with this platform, or not only a visit, to create a really ecosystem to the patient during his journey and during his needs. Hybrid, also digital and physical meetings. And I think it's I'm very exciting because I think it's really only the start of beginning of really new. The second thing that we are going to do, we are doing now in the digital area, is providing services. Not to go. The patient can not go to the ER because after 7 o'clock or 8 o'clock when the clinics are going, they are closed. We have an emergency care. We can talk with the doctor, digital or telephone. The doctors can eye connect services with another specialist. We have from house and off of the clinics remote expert centers. We are using really a lot of services at home and in the clinics for the patient. Instead of going to the hospital or to the ER or the outpatient, and it's used for them. Now in these days when the lot of traffic and a lot of time going from hospital to hospital, from clinics to hospital, this is really very good services. We are going to hear about title here. Also, Mauchedet have the sensor at home. Also, the home is going to be the new clinic. Maybe the home will be a clinic. It's only the start of. We have a lot of patients that waiting for us to develop really a clinic at home. The title, we have a home diagnostic lab, and now we have a lot of in our lab a lot of sensor that can provide services from the house or from the home of the patient. Sorry. Decision support system. Also, the patient, also the doctors needs really decision support system. Also to reduce malpractice and also to increase quality. And we are also developing now a lot of decision support system. This is, for example, for pregnancy, but we have a lot of decision support system. Also, in healthcare, there is a lot of bureaucracy. We have certificate center for surgery, for drugs, for consolation, refunds of invoice, and we do a lot of automation for the patient to reduce the whole bureaucracy, and he can from home to ask for or the doctor for him or the patient himself to ask for one of the drugs or one of the surgery, and in 1 minute he got an answer for his request. Back in the days, we have 4 days or 5 days until you get an answer which kind of medication they recommended, and if to do the surgery, not to do it, to go to specialists, which specialists. And now we do a lot of automation about the whole administrative area and fields. Remote monitoring and management of special population like corona, CHF, pregnant women, COPD, chronic patients. I think control and monitor tools are needed, and they are great for special population. And also in this area, we are going to increase and also to do some of them hybrid, some of them with the call center, digital, and some of them with the doctor, the GP of the patient. Is it a great outcome and a great patient journey, and I think our purpose in Meuchedet is really striving for exceptional medical services experience. I think we are coming here in the morning to do this, really to do an exceptional medical service experience, because people are sick and also not sick. Also, people are wanted to be better and healthy. And we are here to developing transformational models of next generation, how to do healthcare else, some smart hybrid medicine, high quality, available, accessible, efficient medicine, with unique personal service experience. I think this is what I'm coming every day to my office. And this is the potential collaboration areas that I can see for the future: patient adherence, engagement and disease management, prevention, education to patient and medical teams, value-based medicine models, and also a lot of clinical trials. I think this is our really the area that we can do a collaboration with hospital, with pharma, with other suppliers. Thank you very much.
Thank you so much, Sigal, for that great presentation. And I had the pleasure of talking to you a few weeks ago when I asked if you could be a speaker at this event. You made some excellent points in the interview, and you just confirmed them when we talked. And one of the things that we talked about, and I would like you to share with the audience, is not everybody is a digital eligible patient. So how do we ensure now going forward that we're able to provide the same professional care for the patient, for any patient type that is out there?
I think this is the really challenge to do the hybrid one, to design every service also digital and also physical. So now in these days, we're in design services. They design the services also for people that we know that they can't be really digital. And also we are going to use the TV at home. And it's it's only a course with double click, the TV, and we'll bring on the TV at home some of the services, but some of them will be physical also. So to design these services also to very digital people, and some of the people maybe will use the TV, and some people will not use not the TV and not the digital. This is, I think, the challenge, and we have to do also, because I think maybe 25% of the people will not be able to use the digital, and it's a lot of people. 25%, it's a lot of people that we continue bring the medicine like we did before, but we have to be better also with them. So we design new things also for them.
Fantastic. And listening to you and seeing everything that you are able now to offer patients that come in, what is the feedback? Are people happy with this change? Are the patients happy with this digital change that is taking place?
Okay, so the patients who use it are very, very happy. They are thrilled, not happy. I get today, even they sent me, some of the patients sent me a book to read, like a thank you. One of my patients sent me today. Who is using it? They are thrilled. They say, "Wow, I'm in 5-10 minutes from my office or from my home. I finished all my question or discussion with my doctor or my nurse, or with my nutrition or psychology." A lot of people use it. Those, I think the implementation will take a long time. I think the acceleration of the corona was huge, but we have to bring new models how to promote the health of the patient during these models to recognize to the people the digital. I think only digital, only to put platform or robust platform, good platform. It's not the good implementation. I think with the new models to convince the patient that it's okay to use also digital and also digital and physical visits together will be much better than only physical patient. We have a trip to do. We have a roadmap.
Fantastic. I absolutely agree with you. And again, thank you so much for sharing your thoughts and ideas with us tonight. It's highly, highly appreciated. I'm just getting feedback that your message is now getting through to all the continents around the globe. So this is truly a global message you're sending out tonight. Thank you so much
for
your presentation.
Bye-bye.
Thank you. So for our next speaker, a few weeks ago, reading the local the national newspaper here in Israel, it was Times of Israel. The headline that struck against me was, "The robot will see you now." So imagine that, the robot will see you now. So this was the headline in an article by Times of Israel just a few weeks ago. And with that startling prediction that within a decade, more than 90% of surgical procedures will be performed by robots, and 70% of all hospital visits will take place in the patient's own home using telemedicine. And by saying that, I believe our next speaker certainly is raising the bar on what to expect from the future. And from Sheba Hospital, ranked by Newsweek as one of the 10 top hospitals globally, please welcome Mr. Eyal Simlichman, Deputy Director, Chief Medical Officer, and Chief Innovation Officer at Sheba Medical Center. So, Mr. Simlichman, please, the word is yours.
Thank you very much, Hugo. Waiting a second for my slides to appear. And I'll try to raise the bar even higher than already mentioned.
Thank you.
Thank you. So I can see my slides. A few words about Sheba Medical Center. As mentioned, Sheba is, for those of you less familiar, Sheba is the largest medical center in Israel, also largest in the Middle East. We have about 2,000 beds on one very large campus that looks like a small city. When on campus, we have an acute care hospital, a rehabilitation hospital, a cancer center, a children's hospital, and a women's hospital. And of course, a very extensive both research and innovation infrastructure. And of course, I'll talk more about that. And Sheba was ranked, as you mentioned, just this year in 2020 as number 9 in the world by Newsweek. And a big part of that is because of innovation and research that we've been really pushing the limit on many accounts. And the story that I'm about to unfold, I think, will tell some of that. About 4 years ago, I was the chief medical officer here at Sheba, and I was asked by our new CEO to also come in and lead innovation. And it was clear to me that if I'm going to lead innovation at Sheba, which is always trying to be in the front of anything that we're trying to conduct here, it was clear that we need to come up with a clear strategy. And the strategy came up to be this ARC concept. And ARC is not an innovation center. Many people ask me what ARC really is. It's not an innovation center, but rather a platform or an ecosystem, a global ecosystem that you'll see in a few slides, the magnitude of ARC today. And it stands for Accelerate, Redesign, and Collaborate. Accelerate innovation to redesign healthcare by collaborating with partners. And at the end of the day, the ultimate goal of ARC is to redesign healthcare by the year 2030, to bring this huge transformation that we all believe will happen in the next 10 years. And Hugo, you mentioned a couple of these changes that we think will unfold in the next decade. And the COVID pandemic will only accelerate some of those changes. So we're in for a very big task in the next 10 years, and we thought we want to take a leadership position on that. ARC is based on 4 fundamental principles. First of all, it's focusing on digital health. We've been very focused throughout many, many years going back on both the pharma world and the medical device world. We've had some very successful endeavors in the past 20 years where companies that span out of Sheba were sold on the market for hundreds of millions of dollars, both on the device and pharma space. But digital health is really what's going to create the most transformation in the next decade, as we're hearing in this webinar. So the first thing we understood is we have to build a capacity within digital health. Digital health has to be the third leg of what we're focusing here on Sheba. We're still working on pharma and medical device, but we've built our capacity in digital health in the past 4 years, and you'll see to the extent of what was done here. The second is open innovation. And open innovation means you work together with the industry, together with startup companies to recreate healthcare. It's not about us and them, but looking for the win-win scenario where everybody gets to take this forward. Of course, when you live in Israel in this incredible environment of startup companies, what the first thing we try to do is build a startup-friendly environment at Sheba that allows startups to come in and really receive everything they need 360 degrees to fast-track their innovation, to fast-track development, and to keep them on target in terms of where the market needs are. So open innovation is critical for us. Third, it's international collaborations, because no matter how big you are and how many beds you have, you will not be able to change healthcare alone. You have to work together with partners. And that's why collaboration is the C for ARC, and it's a critical part of the strategy. And I'll say more words about that. And then there's the innovation infrastructure that is needed. We can talk all day about innovation, but without the right infrastructure in place, it's very, very difficult to bring this to the next level. And infrastructure is not only the physical space, which we've built at Sheba, and you're all welcome to come and see, but it's also the data infrastructure that is needed, of course, these days. And data is the oxygen that makes digital innovations thrive. And it's also the right policy and regulation you're setting for yourself. Sheba is a government hospital, so we have to work within the framework of the government regulations, and we're working very hard to change that and affect that so that we can move faster forward. It's an integral part of the infrastructure we see for innovation. So what is the innovation that will enable the transformation? Without going into all the details, because it'll take me much more than 10 minutes to do that, we're looking at 4 areas where we're focusing on. The first is telehealth, and COVID has really proven us how important telehealth is. We, of course, understood that before COVID and already built the systems in place. And when we say telehealth, it's not just about the platform that will allow you to have video conference with your doctor, but also the solutions that will allow you to turn your home environment into a hospital environment. And Hugo, as you mentioned, in 10 years, have 70% of what currently we have in hospitals transition to the home level. That's going to be a huge change in healthcare. And when people ask me what's the one thing that's going to impact healthcare most, it's the hospital at home concept that's going to have huge ramifications on the healthcare market on all accounts, whether you're a pharma company, a device company, a healthcare provider, an insurance company, and so on. So telehealth is huge here. The second is artificial intelligence, and artificial intelligence specifically will allow us to make much better decisions, to prevent, to first of all predict, then prevent, and if we fail, only then cure, and if we fail with curing, do the rehabilitation. AI is going to play a role across all of those, and again, I won't have time to go into the details here. The third is virtual reality and augmented reality, not only used for training of healthcare professionals or for rehabilitation, as we're seeing done today around the world, but also for treating patients. And this is where it's going to have the biggest impact. We are treating patients now at Sheba for pain with virtual reality, and we're able to bring down the medication, the analgesics, using virtual reality. We have a lot of hope towards that, and also treating depression and anxiety. Sorry, pharma companies, there's another competitor in the market. And then finally, it's the robotics, as mentioned, and the biggest impact is going to be conducted through robots in the surgical room. And the surgical robots today, coupled with the AI tools of tomorrow, will enable an autopilot that will do the surgery for most of what will be conducting surgery in the future, much like we're flying on commercial jets today, or at least how we used to fly on commercial jets. So these are the 6 areas we're focusing on when we talk about digital health. And I mentioned 4 of them. The other 2 are specifically the operating room of the future. We're doing huge efforts together with some partners to redesign the operating room of the future. And this is critical. Of course, I mentioned the robotics. It's only one part of it, and augmented reality and so on. And rehabilitation is the other addition here, because rehabilitation has really not changed in the past 50, 60 years. And it's going to be incredibly transformed in the next decade. And again, we want to be ahead of the game here. In terms of international collaborations, we're working with the leading institutions. They are all part of ARC. I won't name the names, of course. You're seeing them here in the photo, and it's not the full list. Mostly in North America, that's where most of our connections run, but also in Europe, and we're trying to extend beyond that as well. And we're working very closely with academic medical centers, industry partners, innovation communities, data networks, to really transform healthcare together, to share this vision of how healthcare needs to look like in the year 2030, and work in a coordinated fashion. And it is difficult. You could imagine these kind of players trying to work in a coordinated fashion. It's not easy. We devote a lot of attention and a lot of energy into this work. We have a huge team at ARC that does only collaborations and only integration between other healthcare systems and other partners. And it's a big effort, a big part of the strategy, as mentioned. We have close to 70 startup companies that are ARC members. About half span out of Sheba during the last 10 years. The other half are startup companies from outside that are coming to work with us. And we identify the ones where we think they would play a critical role in the redesign of the healthcare system of the future towards healthcare 2030. It's a lot of reverse engineering, starting with the vision and then looking for the right solutions in the market today. And this is when we reach out to companies such as the companies you see here. Strategic partners, you see these small companies that we work very closely with. We have very strong, again, collaboration efforts, and it's all part of a big strategy. It's about sharing a vision and pushing that vision forward. And some of these partners that we have here really are doing some immense work and working very closely with us as well. Of course, telemedicine is a big issue right now, and without having the time to go through what we're doing in telemedicine, I would generally say we're doing a huge effort in acute care, in chronic disease management, and in rehabilitation. And this is actually working already today. The hospital at home for medicine patients, the hospital at home for psychiatric patients, again, part of our philosophy to push care outside of the hospital, although we're a hospital and we might be hurting our own business, but still we think this is where healthcare needs to move forward. We have a program called MICA, Managed Integrated Continuous Care Application, working now on 6 different chronic disease management, utilizing very sophisticated technology with AI tools, and of course, care management in a multidisciplinary approach. And this is currently running right now, as I said, in 6 different conditions, and in rehabilitation, both telerehabilitation, which started in 2012, well before everybody started to talk about telehealth. More than 60,000 sessions of telehealth already conducted through the platform. and telecardiac rehabilitation, which we're leading the world in that as well. I think we heard about hybrid models, and we're looking at hybrid models as well. I won't have time to describe the whole model, but moving from traditional hospitals to hybrid hospitals for acute care hospitalizations, where the hospitalization can take care physically at the hospital or at the home, regardless of where the patient is. It's being conducted and run by the medicine department, 36 beds. Imagine 18 beds physical at the hospital, metal beds as we know them today, and the other 18 at the patient home. And patients can transition from one bed to another, but the same medical team is taking care of those patients. This is where we're going. This is where the world is going. And we're seeing this kind of movement in the US, in Canada, and in some of the European countries as well. Some of the technologies we're using for both monitoring, communication, and physical examination. Again, we have to mention Taito. They're obviously leading in this world in terms of allowing us to perform physical examination. We've exposed many of our clinical teams to working with Taito during the COVID pandemic right now. And what we've found is that they all find it very easy to work with. And it really transitions how doctors today are working. Before COVID, maybe 5% of our doctors had experience using Taito. Now, 70, 80% of our doctors have experience, and it's generally a positive experience. So we have high hopes that post-COVID, this will continue as well. And of course, COVID is something that we cannot disregard during these days, of course. And it was really, when we started working on innovations for COVID, I call it ARC meets COVID-19, because it was really a huge explosion of innovation. I can't really explain to you the amount of innovation that came out, but just imagine 45 different inventions, 40 patents, 15 commercial agreements, and 3 products on the shelf that were newly designed in a matter of 4 months during the first wave of COVID. It's really incredible, and it's now being looked at as one of the case studies of innovation in times of crisis. Our zero-touch telemedicine toolkit, I mentioned a couple of the technologies, but also Early Sense and BioBeat for monitoring, and Datos, which is our management application to really streamline all the data. This was our comprehensive toolkit. And also, it's not just about telemedicine, as I had told you before. It's also about the artificial intelligence. And what we have done with COVID is really bring up all of the data that we have on our patients to the cloud and provide free access to any data group in the country that wants to work on the data and come up with insights. In times of emergency, it's about all of us working together. So we had 40 data groups from both healthcare organizations, but also defense organizations, and also the military, and also fintech and other sectors that came to work on top of our data during the times of crisis to come up with new innovation, come up with new understanding of COVID-19 disease. And this has really been a huge effort. Intel actually won first place in the competition we've had after 4 months of working on the data, and their algorithms are now implemented at Sheba, and our doctors are using them to make better decision making. And really, just to finalize, this is the whole ARC network in terms of the different stakeholders, and it's all of us working together in this coordinated effort to really transform healthcare in the next decade. It's not a Sheba effort alone, but really coordinated. So I'll end with that. Thank you very much.
Whoa, what can I say? Fantastic presentation, highly interesting. I guess if we put you in a time capsule and sent you 8 to 10 years back and you would do the same presentation, people would just be shaking their heads and say, this is science fiction. But great presentation, Eyal. And just a quick question for you. I think we have time for a quick question. Looking at what you are doing at Sheba, what would you say is different with the approach that you are choosing than from the other pharma or from the other hospitals that are also choosing to go digital now? What distinguishes you from other hospitals?
First of all, Sheba has always been a leader in research. And as a leader in research, we're pushing the envelope towards innovation. I see research and innovation as being along the same spectrum. At the end of the day, it's coming up with something new that does not exist today. So it's not about implementing existing technology, but it's about creating something new, whether it's a core technology or a new service that utilizes several technologies. And what we're doing, as I've explained before, is we're looking at the end result. We spend a huge amount of effort to put together this vision of healthcare in the future, trying to bridge the gaps that we all understand that currently exist in healthcare, and then reverse engineer that backwards. What are the bricks of solutions that are needed to build this wall of a vision? And when we have a brick that is an existing solution in the market, we reach out and bring it into the ecosystem. But when we can't find an existing solution, we invent it. And that, I think, is the different approach that we have, and that's what captures the audience in ARC and brings in these other partners to join hands in this endeavor.
Fantastic. Thank you so much. And I'm sure I'm not the only one online and taking you up on the invitation to learn more about what's happening at Sheba going forward. Thank you so much for a great presentation.
Thank you very much.
So, introducing the next speaker. As you understood, I'm using quotes from newspapers. Seems all the time when I'm introducing a new speaker, I'm going to do the same this time as well. And this headline was basically screaming at me and says, "The Israeli who can predict the future." So the Israeli who can predict the future, and that's just one out of many sentences that has been used to describe our next speaker, Kira Rudinsky. And you may recognize the name, and some of you have maybe already seen her on TED Talks. She made Forbes 30 under 30 list. She's a computer scientist, an inventor, an entrepreneur, and she's specializing in predictive data mining. So Kira, please, the word is yours.
Hi, everybody. So at this time, I decided to talk about one of the main problems that we see today in healthcare, and so much accelerated during COVID. It's the fact that we're overcrowding that we see today in hospitals and in primary care specifically, which is causing lots of medical errors. A lot of those are eventually coming from the fact that, hey, we just don't have enough clinicians. In the United States alone, there is a shortage of 60 to 90,000 physicians. This eventually causes us to see more and more emergency department visits, and it's actually growing disproportionately differently than the population. The population is aging, and the number of emergency department visits is growing by per 100 people. And by 2030, we're going to have 3.8 billion people without access to primary care. And if today people are waiting 3.6 hours on average inside the emergency departments in Israel, 3 hours in the United States, we're talking about 8 hours and more waiting times inside the emergency departments. And again, this is not a prediction. This is how long people are waiting on average in different locations in China. So what we've been building today in diagnostic robotics is the capability of taking everything known in the medical ecosystem, specifically around primary care and emergency departments knowledge, 19 million different medical articles, billions of medical records, combining all of those and building hundreds of different machine learning algorithms capable of predicting how urgent the patient is, which test they need to do, which doctor they need to be seen. We then started working in different triage scenarios inside the emergency department. You see those AI stations. A patient would come into one of those AI stations, and while waiting for a doctor and nurse to triage them, he would answer a set of clinical questions. The system would then predict the urgency of the patient, maybe they need a test, send them those tests. While waiting for the test to be returned, and every time a result is coming back, the system updates the probabilities and creates medical summaries for the doctors. So eventually there is full dashboards inside the emergency department showing urgencies of patients, creating medical summaries for those, etc. But what I actually wanted to talk to you about is a little bit about how you build those type of systems. So I mentioned that we had access to billions of different medical visits. Eventually, those were free texts, and we needed to build a system that can read those texts, extract answers to clinical questions. So for each patient, we had their answers to triage questions, and eventually, historically, what the doctor decided to do, which test to send, their urgency, and even diagnosis. So the system would then correlate the answers to those clinical questions and the final diagnosis. From different trials, specifically in this paper, it has been shown that the system Both red and blue are AI-driven systems. This is where the doctors. So it's not as perfect as the doctors. This is 92. Doctors are at 98. And what we've been doing for the last few years is trying to close this gap between 92 and 98. So first of all, why is this a hard problem? So medical summaries are not just free text. There's lots of negation written in them. So we needed to build a deep learning model that can read those texts and identify what a patient says that they do not have a certain symptom. For this, we have an entire operation of physicians labeling texts and saying, well, this is negated and this is not. The second part is many times doctors do not write those medical summaries for an AI algorithm to read them and extract answers to clinical triage questions. Many times they have what we call latent entities. For example, a patient was admitted with a hypertension along with accompanying conditions. So for every doctor reading this, they understand what it means. For a computer, they actually need to understand more deeper what are those conditions that a doctor didn't mention, but they were probably in the text. So we started building additional deep learning models, trying to extract those latent information from the text that doctors implied but never wrote inside the text itself. We then moved to prospective trials. Our models have reached AUCs of more than 92 in retrospective analysis. But then we started noticing something very interesting in prospective trials, and we've been running those in several hospitals in Israel and in Mayo Clinic in the United States. It turns out that when patients come to the hospital and complain about a constant pain in the chest, how many times would you think the doctor would actually document a constant pain in the chest? So the following number is going to be surprising to some of you. Less than 20% of the time. 60% of the time, the doctor would write that the pain comes and goes, 20% that the pain disappeared. Here's another example. 21% of patients with a chest pain would say that the pain radiates to the left side. How many times would the doctor say that it actually radiates to the left side? 5%. And it's not because the doctors are not listening. It's because they know to ask questions in a different way, to actually understand the physical condition of the patient. This is the art of doing patient history taking. And this is the art that we must master in artificial intelligence, very similar to what doctors are doing. So instead of just asking, is this the worst pain that you've ever had? We will just ask, is this feeling like a hammer to your head? It turns out that we identify that there's many proxy questions that are eventually going to make the distributions between what patients report and what doctors document to be very similar to apply those deep learning models. So how well do these models perform? This is results from one of the hospitals in Israel working with us. So we had access with them to 800,000 emergency department visits. Out of those, 30,000 headaches, and I'm going to be showing those as an example. We had a little bit of more females than males in the data set itself. Eventually, we came to a result that 80% of the time, the system got the diagnosis right. But if you look at differential diagnosis, in other words, how many times the right diagnosis was either first or second, it's 93% of the time, and this is 98% of the time. Now remember, this is predicting the end diagnosis based on only questioning the patient without a single test. So these results are quite interesting. Of course, they cannot replace the doctor, replace the test, but indeed for triaging, they might be an extremely useful tool. We also then started predicting different type of resources that need to be done to also help as a decision support system for the doctors, or more importantly, increase the throughput to start doing the scheduling for some of those. We've reached very different results for different type of chest pain, and it varies from different hospitals, but all of them range, the lowest one is 75, some of them are 80, but we've been reaching to even higher ones like 92 and 93 for certain tests. I'm just showing you that for some, I'm not only showing for headache, we also have wonderful results for back pain, etc. All of those are already published. So let's look at a patient. This is a 35-year-old patient that comes with a headache. What a system is predicting, apologies. He came to the ED, a 5-day history of left-sided sharp temporal headache. Each episode lasts for about 5 hours. The pain is accompanied by eye pressure, sensation, pain, and lacrimation. If you ask the system what is the prediction, it says it's 99 times higher prediction for cluster headache And why? Because of the lacrimation and pain and discomfort. Some of our predictions are completely right, and this one is correct, but some of the times if you do a physical test, like in this case, an ENT actually did an exam, and he verified that it was a sinusitis, which the system thought is only 2 times higher the probability because of the cold and stuffy nose, and because it started 5 days ago. So again, just taking the clinical anamnesis is not enough. Tests are still useful, but for triaging and understanding who needs the specialist, who needs a certain test, quite useful. And this is not only something that we've tested in Israel or in the United States. Let's take a completely different population, the Singapore Army. Let's take their headaches. A lot of them are headaches which are just general, meaning benign. A lot of migrants, much more than, for example, in the emergency department. But when we saw that we can take the models trained in emergency departments around the world and apply on this population, we're reaching area under curves which are very similar, even a bit higher. What's more important is that in the data set of Singapore, in the army, they only had very few cases of meningitis in the past. In the hospital, we've seen so many of them that we were able to build a machine learning model, take it from and transfer this from the Israeli ecosystem, United States ecosystem, test this in Singapore, and reach an AUC of 94. When you only learned it on Singapore data, the results were good, but much lower than transferring the knowledge from all of the other countries combined with large data sets to do this type of predictions. But I started this talk with the fact that till 2030, we're going to have 3.8 billion people without access to primary care. So how exactly will automating those overcrowded emergency departments will be helpful? This is a really good question. So what we've decided is to try to take those type of systems, and this time from home. 30 to 70% of emergency department visits could have been handled somewhere else than the emergency department. It cost the United States alone around $200 billion that could have been saved. So what we're doing today, we're integrating to different health plans. During the scheduling, different digital front doors. We ask exactly the same clinical questions that we would be asked inside the emergency department, predicting that, for example, this patient probably has a UTI. Instead of them going to the doctor sending them to a urine test, the system gives a high probability, and there is an automation rule behind the scenes saying that everything about 30% should do a UTI before. Once the patient does the UTI at home, or in a lab, the system comes back, updates the UTI probability to 90%. A red flag is sent to the primary care physician that can remotely approve this. So here we're talking about a system that was clinically validated inside the emergency department, but the real revolution is building what we call the digital healthcare platform that allows us to automate a lot of the workflows in primary care. Thank you.
Kira, thank you. What an amazing and interesting presentation you made for us today. I'm going to go a little bit back to my introduction of you and playing a little bit with the title you were given, the Israeli who's able to predict the future. So if I may use that one and ask you to look into the crystal ball, what do you think will be the most revolutionary and biggest changes that we will see in digital health in the years to come, except for the things that we know now?
Right. So I think what we've realized right now, as mentioned before during COVID, is there's so many things that we can do virtually. Before that, who would have thought that we can do so much business, talk to people, have webinars just like that, and not a physical conference? The same thing is happening in digital healthcare. People understand that they don't want to meet the doctor physically all the time. We understand that we have to do asynchronous methods to scale the primary care physician significantly. I personally believe that we need to start specifically with triage and clinical triage specifically that can actually help scale the doctors. A primary care physician today has on average 2,000 patients they're in charge of, 5,000 in some countries. Think about this. They cannot know what's happening with each and every patient. So proactive understanding and AI models running on this historical data, predicting patients that deteriorate, and looping in the primary care physician when needed, this is the next digital revolution in healthcare.
Thank you so much, Kira. Highly appreciated. And I really hope to see you again later at another occasion where you can give us another presentation. I know you have a lot of topics you can talk about. Thank you so much.
Sure.
We're moving on in the program. I'm getting really exhausted here because there is so much information to take in. Fantastic speakers, and I'm sure we could have given them a lot more time to dig into their topics. We have one more speaker left for tonight, and you heard the company's name being mentioned several times already, and that is TytoCare. So. TytoCare is the next company that's going to be presented here, and it represents, it's one of the most advanced and successful Israeli companies in the area of home health technology devices and telemedicine. So, TytoCare, and you saw some example, their solution enables remote medical exams of the lungs, the heart, the throat, and ears, and just to mention a few examples, and you will see more. In addition, at this point, Tyto is also exploring how to introduce new advanced product capabilities, including AI and machine learning-based home diagnostic solution. Eyal Baum, which is going to speak next, he's the Director of Strategic Accounts at TytoCare. And Eyal, please, the word is yours.
Hi, everyone. Thank you, Hugo, and definitely an honor to present our company and product in this webinar. So I'll try to briefly go over our company, our product, our capabilities, and a glimpse about our activities in the different markets. Just as background, telehealth, as previously mentioned here, is definitely maybe the hottest segment, hottest trend now today in healthcare, especially after COVID. You see the numbers here; they are growing rapidly, and anyone has expected, a year ago. But beyond very higher adoption, we also see a change of regulations in favor of telemedicine. We see governments, not only the US, which is, let's say, the most advanced in this aspect, but also in Europe, in Asia. We see everywhere government, Ministry of Health are changing the regulation to increase the adoption, to allow treating more type of conditions and reduce the barriers to adopt telehealth. And also we see reimbursement for telehealth changing in everywhere in Europe and in Asia and in Israel, of course. Okay. But eventually, if you look at telehealth, today, especially with COVID, everyone has done a everyone has done a phone call with a doctor, probably also a video with a doctor, and those are, let's say, the traditional methods to communicate with a provider, with a physician remotely. But if you look eventually on this encounter of just video or phone, it's very limited to what you as a patient or what you as a doctor get if you go to a physical clinic. And Tyto is trying to bridge this gap, to really replicate what you as a doctor, what you as a physician get in a virtual encounter. Because this gap leads to a lack of trust. And we see that eventually, although, the potential is great and everyone are talking about it and definitely see this is the future, but if you look today, whether patients are using that, it's still limited. And doctors are not feeling confident enough to provide the full treatment. And this is exactly where Tyto comes in. Tyto is trying to provide the doctor, when he's doing a phone call or a video call with the patient, to also add another layer to this virtual visit of the examination, the physical examination. What all doctors have capabilities in a clinic, now they are not feeling they are limited. They don't need to guess. They don't need to the patients don't need to feel they are compromising on the level of care they are getting remotely. And this really enables to save completely the visit. Okay, so not in 100% of the times, of course, but it's not just initial consult until you get to the clinic, but really saving the encounters. And of course, saving the cost for the payers, for the insurance companies, and for the governments. So it's basically a kit of connected devices. It has a digital stethoscope that allows heart or lungs or even abdominal auscultation, listening to the sounds or measuring heart rate. It has an otoscope to look at the ears, examination camera with a tongue depressor to look at the throat, and a skin camera, non-contact thermometer, and optionally, if needed, we can integrate with other off-the-shelf sensors. Of course, the entire product is FDA cleared, CE cleared. It's a medical device for diagnostic purposes by all means. In addition to the devices, we have a full end-to-end platform. Okay, so it's not just the connected devices. It's in order to provide the doctor a real confident and intuitive and seamless experience, and also for the patient, you need our platform. So the doctor can get remote control of the devices. Keep in mind, Title is not just vitals, it's qualitative examination. So you need videos and sounds and images, and it's basically an examination done by two, both by the remote physician and by the patient or the nurse, if it's done on a real-time usage. Of course, it's HIPAA and GDPR compliant. We are, of course, aware of data privacy and security. This is an essential part of the system. There are customers that already have a platform or wanted to integrate into the medical records. So, of course, we have a very flexible API to integrate into other platforms. So in terms of the experience, how the examination is being done, we support two methods. One is online live as part of a virtual consult, as part of a video call, or offline asynchronous, where the patient is collecting the data, and using our AI capabilities, we allow anyone, not just health professionals or nurses, to capture this data in diagnostic quality, but also consumers, patients who usually don't know how an eardrum looks like, or how the tonsils look like, or how to capture high quality sound of the breathing sounds or heartbeats. So this is why we have invested a lot of development efforts to allow anyone to do a physical exam from home. So just to give you a notion, what does it mean? So let's say a mom has a kid with a fever and some ear pain. So beyond having our mobile app explaining and teaching the mom how to do it, during the examination, we provide image-based processing that guides us through the canal and also confirms that the eardrum was identified, so the doctor will be able to really provide treatment and diagnosis based on this video. And same goes for the throat. So we need to make sure the kid opened the mouth wide enough and said, otherwise we will tell it to do it again and use the tongue depressor. So we verify that the data collected in the offline, the asynchronous mode, will not result in some disappointment, but really allow the doctor to provide treatment when he's getting it offline. And same goes for the stethoscope. You see, we provide ongoing feedback on the quality of the sound. This is the green indication, or otherwise we will give notification to the user whether he needs to improve the sound, keep quiet, and improve the examination. So this was the example of the offline mode. This is the online mode. This is what you see as the doctor side, okay? So you as a doctor are performing a video call with the patient, and in parallel, you are getting in remote control of the device. So when the patient is placing the stethoscope on the chest, the doctor is getting real-time sound from the patient's heart, from the patient's lungs, or even abdominal sounds. It can get the heart rate. It can apply filters if you had some noises or want to amplify the breathing sounds. And if needed, you can select a different point, which is automatically reflected on the patient side. So you see back then in the stethoscope, now it's on the examination camera. You'll see in the ears. We provide the doctor a very confident, intuitive, and easy to use experience. So he will not need to be very tech savvy. He will not to get too much training. And we know that experienced doctors do try to visit today. I mean, the entire session, including documentation and explanation, everything in less than 5 minutes. So we see that doctors are managing to do full physical exam in a virtual consult. And really, we have also statistics saying that in 93% of the times, doctor reported that they didn't need a physical visit afterwards. And this is based on thousands of surveys. So we really see that there are evidence that it's not a temporary solution, but it's really replacing the physical visit. So here you see just example of the common condition for primary care. So we are more targeted for primary care, for pediatrics, but there are certain customers that also use it to monitor certain chronic condition. You see an example, but of course it's not limited to these conditions. We have basically two product lines. One is tied to home, more for home use. You can see an example, chronic patients, elderly, COVID patients, and Tyto Pro, which is more for clinic use in pharmacies, nurses that are doing home care, care homes. school, ambulances. By the way, Israel National Ambulance Service, MADA, MDA are also using Taito. So each customer eventually uses Taito in a little bit different mode. So we are already have good adoption and footprint globally, mainly at the US, but we see expansion in Europe, in Israel, of course, with Clalit, Shiba mentioned here, and other HMOs, Asia, and you see eventually who are our customers, our partners. You see a lot of health systems, hospitals, health insurance, and clinician groups. I want to show you last video before we are ending, a video from Shiba app. No, app. We can go back. Any chance you can go back? Hopefully, let's give it a try. Previous, and if not, let's do one more try. Now I will, maybe because of the remote monitor. Never mind. This is an example of Shiba who used Taito for home hospitalization and monitoring COVID patients. That shows how an online visit in Taito. Basically, Shiba has used Taito as they began with the patients, the Israeli patients that came, now it's starting from the Diamond cruise ship from Japan. But since then, they're using it both in Corona department, pediatric Corona departments. Never mind, I see it's not running, but it's okay. Okay, it just will give you, okay, now it's moving, perfect. Sorry for that. So this is basically allows the remote monitoring of patients at home. So COVID patients with only mild symptoms that do not need to take a hospital bed. So they can take, can get a Taito home kit to their homes to allow Shiba doctors to monitor them and make sure that they're not taking too much risks by sending COVID patients to the homes. So the patient, and you see anyone can do it, logs into the app, gets online in a video call with the remote physician. The physician sees the patient first, then he can connect to the Taito device, measure the vitals like temperature or heart rate or blood pressure. And in addition, if the doctor feels he needs some examinations like the lungs, the throat, the ears, etc., he can make sure that the lungs condition is not deteriorating and the patient do not need to come back to the hospital. So that's, as we see it, gives Shiba and other hospitals the confidence to send more patients to the home, saving costs, saving beds, without taking risk of maybe sending patients who can get into a more serious condition without the proper monitoring. So you see here, it's a very interactive live examination between the patient and the doctor. So the doctor, you see the doctor's side, they see the throat, take the temperature, now the stethoscope, and listening to the lung sounds. So patient just put it on the chest. The doctor in his headphones are listening to the breathing sounds and can identify if there are some wheezings or crackles or either indication or not, or rule out any pneumonia or other clinical condition. So this was an example of the Shiba, how they use it outside the hospital, but as I said, also within the hospital. And let's slide another example from a hospital in Switzerland called Freiburg Hospital. They have a team of nurses, about 20 or more nurses that are going to care homes, to patients' homes, really to monitor those conditions. And if patients are requesting for remote physical exam by a physician. And we have, of course, many other hospitals in Italy, France, UK, and US, and other places. Thank you.
Thank you. During your presentation, I told myself, Hugo, you have to stop using the word science fiction because it's not science fiction. It's actually here already. But what you're showing is simply amazing. I want to ask you a question. So there are so many providers out there now, and you received recognition from Shiba, from the SIGFROM, from Mohedet, from Clalit. What do you think distinguishes you from the other providers of these kind of solutions out there? What is the key success factors of TaitoCare, if I can ask you?
Sure. So as I briefly mentioned in the beginning, telehealth is very widely used today, but it's mostly based on the phone and video. Once you have that additional layer, we call it the third generation of telehealth, that the really capability to do a physical exam is what differentiates us, is what makes us unique, and the capability to allow anyone. So there are maybe other digital stethoscope on the market that you can integrate into your platform, or maybe even a digital otoscope. But first, the comprehensive kit that all these basic tools, basic clinical tools are provided, together with the platform that guiding the patient and provides very intuitive user experience for the doctor and for the patients, allowing to achieve really diagnostic quality data. And this is not easy. Keep in mind, it's not just temperature or blood pressure, that it's a click of a button. Doing a throat exam or ears exam or lungs exam or heart exam, it's not very simple. It's not a click of a button. You do need to find your tonsils. You do need to find your eardrum, or making sure you're not creating noise to the stethoscope sound. So our AI and algorithms definitely makes a difference to achieve diagnostic quality data.
Fantastic, Eyal. Thank you so much for your presentation, and thank you for joining us tonight. And I'm sure we're going to hear a lot more from your company going forward. Thank you.
Thank you.
So, ladies and gentlemen, from all around the world, I've been receiving notes throughout the meeting that people are joining in from pretty much every continent and countries all over the world. It's fantastic to see you. I see we're also receiving great feedback, and this is obviously a topic that has been speaking not only to your minds and heart, but also mine and the team here. So pretty much this brings us to the end of our meeting. I would really like to take the opportunity to thank all the speakers for their excellent contribution tonight. I would also like to thank a lot of people working behind the scenes to making this event possible. And in particular, Nama, Bal, Danit, and Dennis, thank you for your very dedicated effort. And thanks to all of you online for joining us for this experimental event. I hope you enjoyed this as much as I did. I'm really thrilled. I still have goosebumps. I can share that with you. But I also hope it gave you a glance to all the interesting things that are happening here in the Israeli ecosystem. I'm sure you know that the companies don't mind that you reach out to them if you have further questions or any follow-ups after this meeting. On the screen, you will see a quote that I stole from Canada's Prime Minister, Justin Trudeau, and I believe he made it at the World Economic Forum meeting, which he said, "The pace of change has never been this fast, yet it will never be this slow again." With these words, thank you, Leitraot, à bientôt, auf Wiedersehen, goodbye. Thank you so much from me and from the entire Bayer team. All the best.